So my argument in this talk is that palliative care is one of not that many interventions in healthcare that improves quality a lot, and by improving quality, markedly reduces costs. So it affects the numerator and the denominator. It is one of the highest value medical interventions there is. Yet, no mention of it whatsoever in Obamacare. Absolutely no policy passage in support of this kind of care. We can talk about the reason for that another time. But this is an actual patient of ours from Mount Sinai. These two are characters. You can see Mrs. B makes all her own clothes, and she makes a matching tie. And you can see from her face that she is a character. This picture was taken before I met them, which was 2 years ago. I was the attending on the palliative medicine service, carrying the beeper because it was after 5 o'clock, and the rest of the team has to go home at 5. So the fellow and I were still there. And it was a call from the emergency department attending who said, Diane, I really don't know if this consult is appropriate for you because this guy's not dying. This is our emergency room, right? You would think they would know this by now. But this couple is abusing the emergency room. I will never forget that phrase. This couple is abusing the emergency room. He's in here for the 4th time for low back pain. Okay. So this was the story. At the time I met him, he was 88. He's now 90. He had really bad arthritis of the spine, which, by the way, is the #1 cause of disability and symptom distress in Medicare beneficiaries, arthritis. Okay. His arthritis was so bad that whenever he would get up from a chair or up from the toilet, he would kind of spasm and lose the ability to stand up. So in this instance, it was a Thursday evening after dinner. He was in the bathroom. He tried to get up. He hit the floor. So it was like 6:15 or 6:30, and his wife called the doctor's office, as she always does. He always falls after hours, by the way. She called the doctor's office, and what did she get? It was after 5. What did the tape say? Who's abusing the emergency room? So it said, if this is a medical emergency, hang up now and call 911. So she did exactly as she was told. She couldn't get him up. Her only daughter lives, of course, in California, the daughter from California. She did send me the photo, however, so. But she doesn't live anywhere near. She just worries from a distance. And she does. We talked to her from the ED. He described his pain as really severe. He was able to tell us that, when we asked him from 0 to 10, he said 8. And he was taking poisonous doses of Tylenol. His primary doc had said, oh, just take Tylenol. Now, in the primary doc's defense, this is an 88-year-old man with mild to moderate dementia, right? We know that opioids, narcotic pain medicines in people with dementia do increase risk of confusion, do increase risk of falls, that it's very challenging to safely use these drugs in that population. And this physician had had no training in the use of opioids in frail older people and wasn't about to start. And then the other class of drugs is nonsteroidal anti-inflammatory drugs like Motrin or naproxen. Well, in this patient population, that drug category is much more dangerous than opioids, can cause bleeding, can cause renal failure, kidney failure, really, and bleeding, an unsafe drug category for dementia patients frail in their 80s. So what was left? Tylenol, which everyone thinks is safe as water. So it turns out that Tylenol is one of those drugs with a very close relationship between the therapeutic dose and the toxic dose. So you can go up by 2 extra strength a day beyond what you should take and destroy your liver. So a man of this age shouldn't have been taking more than 3 grams total per day. That's 2 extra strength 3 times a day. He was taking 5 grams a day. Fortunately, he had not injured his liver, but he easily could have. And by the way, the Tylenol wasn't helping at all anyway. So he was just getting risk, no benefit. So it turns out we were meeting him for the 4th ED visit in 2 months. He had been hospitalized 3 times in the prior 2 months, each time essentially for the same reason. Falls, back pain. What was put on the coding for billing was weight loss, falls, and he also had a delirium or confusion from constipation. Because when he came in and was agitated and confused, it didn't occur to anybody that it might be due to constipation. So why doesn't somebody just guess what this cost the taxpayer? Okay. Did any of these things require hospitalization? No. Okay. His wife, 5 years younger, was in tears when we met them in the emergency department because he was furious at her for calling 911 and bringing him back to this nightmare place. You know, he said, please don't take me to the hospital. You know, he was really angry at her. He was actually cursing at her in the emergency room, which was very embarrassing for her. And here's what she said. He hates being in the hospital, but what could I do? The pain was terrible and I couldn't reach the doctor, and you know what happened when she tried. I couldn't move him myself, so I called the ambulance. It was the only thing I could do. Who's abusing the emergency room? This is our healthcare system, right? The only place that has to take you after 5 o'clock is the 911 call and the ambulance. There is no safety net other than that. So here's what happened before we met him. 4 calls to 911 in a 3-month period, leading to 4 ED visits and 3 hospitalizations, leading to a very bad hospital-acquired infection that he wouldn't have gotten if he had stayed home. He became incontinent because he was in restraints. The bed rails were up because they were afraid he would fall if he got out of bed, so he became incontinent, which he wasn't before he came to the hospital. And the stress and anxiety of his wife, you know, got higher every day. So what did we do? The first thing we did was give a really tiny dose of morphine to him, 2.5 milligrams of liquid morphine, and just watch him, see how he tolerated it. So we just sat there. Actually, they put us, we have a geriatric emergency room now, and there's some rooms where you can actually be away from the insanity of the ED, and we were in one of those rooms with the 2 of them. And while we were watching him, we just asked Mrs. B how things are going. And we just listened. And how things were going is that she couldn't leave the house because he couldn't come because of his pain. So she was homebound, essentially. She couldn't go to the grocery store or to church or out with her friends because if she left him alone, she was terrified that he would fall or hurt himself. So she wasn't grocery shopping, so what were they eating? Chinese. Because in New York, you can pick up the phone and order just about anything, but all she was used to ordering was Chinese. That was all that was in their refrigerator. She couldn't get her hair done. She couldn't get clothes to the dry cleaners. She didn't know about Fresh Direct. Those of you who don't live in New York might not know either, but in New York, you can, you know, on the computer order whatever you want and it'll come, but she didn't have a computer and didn't know about it. So they were basically both homebound and really socially isolated. And she was determined to keep taking care of him, didn't want any help in the house, didn't want anyone coming in, but was clearly depressed and coming to the end of her rope, I would say. So we gave him a little pain medicine. We listened to her for about an hour. We connected them with a program we have called Visiting Doctors, which is actually a house calls program, and it's not just doctors. It's nurses, it's social workers, it's advanced practice nurses, and it's doctors who go to your house instead of you coming to us. But the great thing about them, aside from that they come to your house, is that they have a 24/7 phone number. So there's no more 911. So if somebody hits the floor at 6:30 p.m., somebody goes to the house to help. And you know, partly because I have connections and partly because he was a palliative care patient, they saw him the next day. he jumped to the top of the queue. Palliative care patients typically jump to the top of the queue. So turns out that she, in particular, was quite a religious person and had been a very active member of their church nearby and hadn't been able to go in 2 years. And for reasons I still don't know, the pastor had not reached out to her. And she had completely lost contact. So we called, and they had a friendly visitor program where they send members of the congregation, and they also had a friendly visitor program that had high school students on community service. So what they set up was 3 afternoons a week. Somebody comes from 3 to 6, Monday, Wednesday, and Friday, to hang out with Mr. B, and Mrs. B gets out. I mean, it was a phone call. It was really not very difficult. We also got her daughter to order Fresh Direct, which she was happy to do. I don't think she knew that her parents were eating Chinese food. We arranged Meals on Wheels to reduce the cooking burden and preparation burden on her. We set up the Friendly Visitor Program. That was 2 years ago. He has not once been back to the ED or the hospital. Now you tell me, is this better quality? Is it cheaper? Why is it cheaper? Because it is better quality.